Hi, and welcome to COMM309 Health Communication. Today, I'm out of my office, finally. This is what I look like in the sunlight. I'm actually spending a nice weekend in Harper's Ferry, only doing a little bit of work, a little lecture recording. Anyway, we're going to be covering Chapter 5 today on intercultural health communication. Well, really, it's just the implications of culture for health communication. And I should say ahead of time, this chapter wasn't really much focused on the strategies or sort of the applications of like, so how do you navigate it? We're more geared about sort of establishing why this is even an important topic to address to begin with. Your book mentions a lot of different problems that can come from when people aren't interculturally competent in healthcare settings, meaning they don't think about a perspective that could be coming from a different culture or how a different culture might view it. And so we're going to be talking about a lot of the different problems that can arise in communication situations when there are those intercultural discrepancies. Some of the things that were specifically mentioned by your book, ignoring cultural diversity can lead to things like inappropriate medical decisions, culturally inappropriate medical decisions. So decisions that might seem right to you, but could have really negative implications for the person getting, for instance, if you're a provider, getting treatment because of different cultural values or expectations that treatment might violate. Also, a lot of fear and anxiety. If you're not thinking about how people that come from different cultures might be perceiving something that you're recommending or doing, or even if it's routine to you, it could create unnecessary fear and anxiety in a medical situation, which isn't good because that can lead to all sorts of negative things aside from problematic, stressful health outcomes. Also, things like non-compliance to different medical behaviors, and maybe even reduced willingness to come back in for healthcare. So we'll talk about that a little bit later too. And of course, patient dissatisfaction, which we know is important for a number of reasons, including, again, those compliance issues we talked about before. If you're feeling more satisfied as a patient, you're more likely to do what your doctor says, come back, right? It's about more than just customer service, right? It's about making sure that you have a good relationship with your healthcare provider. Cultural competence is an indicator of health literacy. Again, one of these buzzwords that keeps coming up in all the chapters we're covering. Health literacy, remember, refers to a person's ability to sort of navigate the complex medical world. It's not just about how well you can read and write, that certainly factors into it. It's how well can you interpret medical messages, navigate medical systems. Do you know who to talk to? Do you have a basic knowledge, for instance, of different types of health and disease issues? Can you understand different types of medical lingo? Those types of things all factor into health literacy. And I think it's fair to say that there's a lot of reasons why people from other cultures, if we're talking about our culture, let's say, if people from another culture come into our U.S. culture, there's a lot of, I'd say, fairly obvious reasons why they may have a hard time and have lower levels of health literacy. Language is one of them, okay? So if English is your second language and everything in our healthcare system is written in English, then obviously they're not going to have high levels of health literacy. They're not going to be able to like navigate that system as well, right? But I really want to make this clear. Intercultural communication isn't just about language barriers. It's about all different types of barriers that can come when people are raised in a different culture, belong to maybe several different cultures, right? And how they see the entire healthcare situation. So when we're talking about health literacy, right, maybe it's not just that they don't understand certain things, but they haven't had experiences in our system. So for instance, the tests that we run, that our doctors perform, might not be the same tests that they're used to seeing, right? So it's not really about can they understand the language? It's like, do they understand the whole process that sort of comes from our culture? This used to not be as big an issue, okay? Like, especially in the US, it was easy. Like, most everybody was white, so we didn't have to worry so much about intercultural competencies. But increasingly, and I'm sure you've heard statistics before, that increasingly we are becoming a multicultural country. And before long, whites are likely to be a minority group instead of a majority group in the country. They say that Latino Latino cultures are the fastest growing ethnicity in our country, followed by Asians, and they're increasing. Their population is increasing at a much higher rate than the white population. But the point is like we really are blended. So it's not even if we had two cultures, right? It would be easy. But it's even more complicated than that because there's different types of cultures too. It's not all about race and ethnicity either. So another reason why this is really important is because there's different healthcare cultures. So you can look at even within the healthcare system, different philosophies, different ways that people from any culture view health and wellness. Okay, your book actually brings up, we're talking about these healthcare cultures, two different types. Let me see where to put up my notes. Right. Actually, well, more. I'm going to go through two. There's the biomedical, right, concepts of health, and those are the ones that you're probably most familiar with. Those are the ones that are represented in our media and represented probably about when I say to you, what do you think of when you see a doctor, right? A guy with a white lab coat, right? Because what the biomedical cultural idea of medicine is basically science, right? It's a scientific method. It's practices and beliefs that stem from this Western idea about what health and wellness is, what healthcare is, those types of things. But there's also these ethnomedical, right? More ethnomedical views on healthcare. And this refers to any sort of, basically anything that's ethnically bound as opposed to Western medicine bound. So the ideas that somebody might have about how their beliefs and knowledge shape their ideas about what healthcare should be, okay? An example your book actually gave was about how one of the things in Western medicine that we sort of take for granted, but it's there, is this belief that the individual, right, is what you're treating, right? The individual is the most important thing, and that's privileged over different types of group concerns. But in more collectivist cultures, this is a very individualist notion. In a culture that's a little bit more collectivist, that believes in the good of the community over the good of the individual, right? Treatment could look very different, because you're not thinking so much about how, let's say, the introduction of a vaccine would affect different individuals, whether or not we approve this vaccine or not. We're thinking about the greater community. So what's good for the community versus what's good for the individual. And so that can affect different types of not just patient decisions, but really like public health decisions too. So that would be an example of an ethnomedical issue that could arise, right? That's much different from our biomedical concept of health. Let's see. I also wanted to talk about, just in general, some of these challenges that are brought up about not about being in a minority group or an immigrant group and navigating our U.S. healthcare system. This is an issue of culture, sort of going back to race and ethnicity. But again, back to the theme of like, why do we even care about this stuff? Well, the truth is that a lot of the healthcare problems in our country can be linked back to these intercultural issues about dealing with underprivileged, underserved, disadvantaged, whatever you want to say. Healthcare disparity is actually a good word for it. So what we're talking about is healthcare disparities. Minorities, people with lower income too, experience a whole lot of different challenges navigating the healthcare system, including, right, we've talked about health literacy. They tend to have lower health literacy because of usually lower levels of education, etc. Maybe they don't speak the language, so that would also be a big barrier. Lack of access to adequate care. So maybe they don't, because it's rural or because it is a financial issue, have the access to really good care. I mean, that's a problem in itself, but it leads to other problems, you understand, because if they're not getting adequate health care coverage throughout the lifespan, then what's going to happen is it's going to culminate into medical emergencies that need to be dealt with later. Lower quality of care. We know that these healthcare disparities that exist with minorities and new immigrants, they tend to get lower quality of care, and that can be linked back to things like language barriers or health literacy barriers, or some of these differences in healthcare philosophies that we talked about before. But it can also be linked back to different stereotypes and stigmas that the providers themselves have about these different groups and how they actually treat them. There's also a high level of mistrust among these more vulnerable populations, which is exactly why we call them vulnerable, right? Because they're at greater risk for being taken advantage of, and they might not be getting the type of care that they should be getting. So one of the examples of this is Black Americans are well known for having a very extreme distrust of the medical system. And actually, it makes a lot of sense why this would be, culturally speaking, because historically they've been taken advantage of. They were volunteered for medical trials that they weren't supposed to be in. There's some really, if anybody's interested in this, post it on the message board and I'll give you some examples, like Tuskegee medical experiments and things where African Americans have been used as basically lab rats. And this creates an extreme distrust of the medical establishment that has actually sort of persisted generation and generation, on and on. Again, the problem with this, though, is that if you have any group who actually, for right or wrong reasons, distrusts the medical establishment, they're not going to get, access to great care. They're going to have lower willingness to comply with things that might be very good for them. And again, this leads to all sorts of issues later on. This is a problem, by the way. This isn't just sort of like let's have a conversation about like, oh, how sad it is to be a minority in this country, though in many ways it can be sad. This affects our larger healthcare, our larger, this affects healthcare policy. It has larger implications for how we distribute tax dollars and things like that. I actually, in the project that I worked on in Atlanta, doing research at an urban hospital to try to figure out why people would call ambulances instead of just going to the emergency room, or even better yet, going to primary care. Because sometimes what would happen is that people would be calling the ambulances for a toothache. Why would you call an ambulance for a toothache? Well, because in these underserved populations, they don't have access to health insurance or any other types of primary medical care. And so really using the emergency system is the only thing that they can do. But of course, this burdens the entire system. Again, I bring this up because this isn't just an isolated issue that's sort of their problem, right? This is a problem we all deal with because the implications of this is that our resources are sort of going to take care of these larger issues that come out of these issues of disadvantaged groups not being able to take care of themselves. So the ongoing challenge is to try to figure out how do we give people access to healthcare so that there's less of a burden in the system. Anyway, I could talk for days about that. Sorry, I keep using the word issue. I keep hearing myself say that. Okay, the other thing I wanted to just sort of bring up that I thought was really important is they mentioned the social implications of illness. And I wanted to talk about this theory that they talk about called social identity theory by Taj Fellin-Turner. So social identity theory, I love this theory. It's not a health theory. It's a theory about how we think about ourselves. It's a theory about our identity. And social identity says that our identity is social, that our identity is often based in group membership. So instead of seeing myself as Elizabeth, sometimes I see myself as Elizabeth, a professor, and I identify with other professors and other people who are in academia. Or I might identify as Elizabeth as the Jew in certain situations because I'm around a bunch of Jewish people and whatever. You can have multiple identities according to social identity theory, and you're sort of made up of these memberships. And social identity also talks about how those memberships can fluctuate and how important they are based on different influences, whether it's media messages or who we're around and things like that. So why is this important? Because some scholars have looked at illness as a social identity, meaning like we can be defined by our diseases because we all of a sudden become a member of cancer survivors or something more stigmatizing like an alcoholic, right? So I'm an alcoholic. I belong to this other group of alcoholics. Forget Alcoholics Anonymous. This is just the idea that you feel like you're part of a particular group. And this is important because a lot of these memberships are stigmatized. I mentioned the alcoholism one. You know, the disease model of alcoholism, looking at alcoholism as a disease instead of just something that people with bad character do, right, drink too much, is relatively new. And so it's very stigmatized. It's an identity that you have about yourself, but it's not something that other people can see. Same thing with mental illness, which tends to be stigmatized as being dangerous and unstable. HIV/AIDS, which nobody likes to talk about because we live in a homophobic culture and because we don't like talking about things that involve sex, right? Cancer even. There's a stigma to cancer, which I don't quite understand, and I have a feeling it has to do with issues we've talked about before about how people are just scared to be around anything that is related to death, you know? But the problem is that when we stigmatize these diseases, the people who have them are also stigmatized, and they ingrain that in their identity, and that makes them less likely to seek help and do other things because they themselves feel shamed, right? That's really what stigma is about. It's about shaming. And the good news is that positive social contact with somebody who has one of these illnesses, one of these diseases, is actually been shown to reduce people's stigma about these things, even if it's through the media. I did a cool study with one of my professors looking at how Monk, the OCD detective, could actually make people who had a mental illness feel better about disclosing their illness because they felt like other people were going to not stigmatize them as much. So there are ways around this, but I just wanted to have a conversation that, you know, as a culture, we have to figure out ways to reduce the stigma in order so that more people can get treatment and eventually we can solve these diseases. Okay. I'm going to go have a beer on that note. That's so terrible after I just did alcoholism. Okay, I really should have thought of a different example. But, so, okay, I am leaving now. I'm going to go on vacation. Bye.